Thank you for the opportunity to speak on molecular diagnostic in critically ill patients with severe pneumonia. I'm an intensivist from Brisbane, and this is my conflict of interest, and I do not have any direct financial conflict of interest for this talk. Briefly, we're going to go through pneumonia as a global challenge that we all face, and just a little bit on COVID-19, which the previous speaker touched on in terms of its inflection point, and as a milestone that opens the potential of molecular diagnostics in our management of pneumonia, and the challenge particularly to intensivists or intensive care specialists in managing pneumonia in the ICU setting. And we will focus on the molecular diagnostic technology that we have now and possibly in the future, and a few projects that we're doing locally in my hospital. And we will talk about the future and hopefully give you a summary by the end. If you look at pre-COVID, community-acquired pneumonia causes about 4 million cases per year in the US, and it is the most frequent cause in infection-related death in the US, and overall is the 8th leading cause of death in the United States before COVID. Obviously, there is a spike of pneumonia-related death in the US during COVID as well. But if you look at Australian data, it's fairly similar. Pneumonia and influenza combined, it is the 8th leading cause of death, and it is the leading cause of hospitalization and mortality among community-acquired infections. And globally, pneumonia is estimated to cause about 2.4 million deaths per year, and it is the leading cause of infection-related death in children under 5, with close to 1 million deaths per year. From an intensive care specialist perspective, pneumonia is also a leading cause of acute respiratory distress syndrome, which requires mechanical ventilations and prolonged ICU stay. If you look at global burden of disease, this is a 2012 publication, and if you look at lower respiratory tract infection, and it ranks #1 in terms of the cause of years of life loss compared to all other causes. So it is a significant burden to the world from a disease perspective. So every year on the 12th of November, we have a World Pneumonia Day to try to raise awareness to the challenge we face in terms of trying to reduce the incidence and reduce morbidity and mortality from this severe disease. And if you look at the etiology of pneumonia, the biggest thing that I want to draw your attention to on this pie chart is 62% of the pneumonia has unknown microbial etiology. This can be due to various factors. This can be due to the fact that our current diagnostic technologies limitations, so we do not pick up all the pathogens. It could be due to the lack of testing, so not every patient will have access to testing in a timely manner. And it could also be due to the fact that a lot of testing of samples are done after the initiation of antimicrobials, so the yield of those tests are even lower. So there are a range of bacteria that cause pneumonia, and there's a range of viruses, and the black section of the pie, 3%, is actually overlapping when you have multi-pathogens. And I believe this section should be bigger as well, but due to the limitations of current testing methodologies, so we do miss a fair bit of pathogens. So we always assume that there is a single pathogen, and we stop looking after we find one. I believe underlying a lot of those infections, there should be a lot of co-infections that happens, especially in the case of severe pneumonia. And this slide summarizes the 3 pillars in pneumonia diagnosis that we base on. The first group is pulmonary symptoms, in terms of cough, dyspnea, sputum production. And the second important element is radiological diagnosis of pulmonary infiltrates. And the third component is the evidence of inflammation either systemically or locally in the lungs. But if all 3 overlap, you can see pneumonia here. It could be bacterial, fungus, or viral. Even when all 3 overlap, you still got a whole range of differential diagnosis. And if you're outside that circle, there's a wide list of differential diagnosis. The pneumonia diagnosis per se, from a clinical, radiological, and inflammatory biomarkers perspective, is imprecise. And that's the limitations that we're living with at the moment, especially having to get antimicrobial into patients early And I remember one of the earlier speakers spoken about the fact that in COVID pneumonia, 71% of patients were exposed to antimicrobial, but co-infections with bacterial pathogens actually less than 10%. So it is a huge issue in terms of what we know and do not know when we face with someone with severe pneumonia, and the empirical treatment itself may or may not be required by the patient. So if you look at our challenges in terms of diagnosing pneumonia, radiological infiltrate, especially on the chest X-ray, is neither sensitive nor specific. You could have pulmonary edema from heart failure, and you could have pulmonary hemorrhage from a pulmonary embolism. So pneumonia per se is not specific on the chest X-ray. A CT chest is slightly more sensitive and specific, but it's not available and it's expensive. Inflammatory markers are definitely not specific. CRP and your procalcitonin are highly non-specific. And if you look at sputum microscopy culture and sensitivity, they are very labor intensive. They're really slow. It takes at least 48 hours, typically 48 to 72 hours for pathogen identification if there's any. And there's high false negative and high false positive rates. And if you look at blood cultures, it is only positive in about 6% of the hospitalized community-acquired pneumonia patients, and about 14 or 15% among patients with severe community-acquired pneumonia. We do have antigen testing, so you can test the urine for Legionella antigen. It only tests for one serotype of Legionella pneumophila. It has better use in the United States, where 80% of the Legionella is caused by this serotype, but in Australia, where I work, less than 50% of Legionella is caused by Legionella pneumophila. A lot of our Legionella is Legionella longbeachii, which is from garden potting mix rather than from air conditioner. So this test has serious limitations in the local setting in Australia, although it has much better utility in the US. And if you look at pneumococcal antigen testing as well, the sensitivity is not high, it's 60 to 65%. And in the Australian setting, where immunization rate is getting higher, and for very peculiar reasons, the antigen testing in the urine, the sensitivity is dropping as the immunization rate goes up, maybe due to the change in antigen compositions on the surface of pneumococcal due to vaccination. So this test is losing its utility as we speak. Just let me advance the slides a little bit. So quickly talking about COVID, so 2021 figure shows that about 3 billion people or more, or 44% of the world's population has been infected with SARS-CoV-2 at least once. So the current figure is probably closer to 70% when the disease has changed from pandemic to endemic. And up to 20% of those patients require hospitalization. Among those, a quarter requires ICU care. So total, about 5% of the total infected population require intensive care for organ support. That's usually related to quite a large degree of morbidity and mortality. One of the things that COVID-19 has done in terms of molecular diagnostic technology is actually open up the world in terms of awareness and understanding of the potential and the utility of molecular diagnostic. While understanding the antigenic phase and different levels of antibody and serological response to COVID-19, we were able to design, collectively the industry were able to design rapidly multiple testing for antigen in the body as well as RNA, and that is an inflection point in my view. It's a milestone in terms of the public awareness and the health industry as well as healthcare practitioners' awareness about molecular diagnostic. And a lot of this is crucial in terms of our public health response, as well as our response at the hospital level in terms of isolations and early initiations of appropriate treatment for COVID-19. So this has set the hallmark and also opened people's eye as to the potential for molecular diagnostics even in non-COVID pneumonia. So from a severe pneumonia perspective, I think there's a lot of definitions about what constitutes severity or severe pneumonia. What I base my therapeutic and also assessment on is something that's issued by the Therapeutic Guidelines of Australia, which I had the privilege of contributing to from the ICU perspective. So to qualify yourself as a severe pneumonia, you either have to have signs of severe acute respiratory insufficiency with tachypnea, hypoxemia, or multilobar or rapid progressions of a chest X-ray infiltrates, or you have to have acute extrapulmonary organ dysfunction, either a low blood pressure, confusion, poor perfusion, poor urine output or poor kidney function, or hyperlactemia. And there are severity scoring systems that allow us to guide or assess the severity, but they usually help us in terms of placing the patient either in hospitals or if they're requiring intensive care. But they do not tell us which pathogen is causing pneumonia. In terms of current testing that's available, even before COVID, we do have rapid antigen tests. Now we have SARS-CoV-2, as well as a combined kit that detects both SARS-CoV-2 and flu A and flu B. We still have the urinary pneumococcal antigen, as well as urinary Legionella antigen testing. We have PCR-based nucleic acid amplification testing, either for COVID or fourplex, including flu A, flu B, RSV, and SARS-CoV-2. We have the typical viral PCR panel that detects flu A/B, RSV, paraflu 1 to 4, adenovirus, human metapneumovirus, and rhinovirus. And in terms of bacterial pathogens, there's been rapid progress in PCR technique to detect bacterial pathogens, especially the atypical bacteria, including Legionella, Chlamydia, Mycoplasma, Pneumocystis jirovecii, as well as Mycobacterium tuberculosis. And what I want to focus our talk on for the subsequent time is the technology that enables PCR-based multiplex pneumonia pathogen testing. I think that's the potential for us to refine our approach in terms of the diagnostics for severe pneumonia. And from my institution's perspective, the BioFire Film Array Pneumonia Plus panel is the only one approved for testing and use in Australia. So we have obtained technological approval to try to implement this in our hospital. And this is a 34 target, including 18 bacteria as listed here, 9 viruses, the atypical bacteria is included, and 7 resistant genes, including carbapenemases, ESBL, CTXN, as well as the MRSA gene detection. So the whole testing takes only 1 hour, and the PCR technique is basically using a series of cycle of denaturations and annihilation to try to multiply the copies of DNA. And this technology is incorporated in the cartridge with minimal user input. So from our point of view, you can do the testing on respiratory samples, either a sputum sample, a aspirate, or a bronchoalveolar lavage sample, and it will give you the results in 1 hour instead of the usual 48 to 72 hours. So one of my colleagues, Dr. Hamish Rutledge, has done a literature review prior to us adopting this at the local hospitals. So we look at a total of 30 studies published between 2018 and 2022, and looking at the microbiological performance of the BioFire Film Array testing. We found the sensitivity ranges between about 90% to 100%, and the specificity ranges between 76% to 100%, with the standard of care as the sputum culture as a standard of care. And we'll talk about why the specificity is a bit lower here. That's in regard to the validity of sputum culture as a standard of care. And the turnaround time is between 1 to 3 hours because you have sample collection and sample transport to the lab. And earlier pathogen identification is usually up to the degree of a day, up to 3 days compared to the standard of care. And this potential impact on practice from published studies of between 40 to 80% of the patients, involving de-escalation antibiotics in 21 to 48% of patients, escalations or the coverage in about between 6% to about 28%, and additional clinical measures, including isolation, up to 30% reported in one study. So overall, it does change clinical practice. What we want is to try to translate that to local practice in the Australia setting. And one of the things that I talk about is the sputum microbe culture as the standard of care. If you look at this pie chart, this is provided by the company, and looking at this turquoise section of the pie chart, from a BAL specimen, the bronchoalveolar lavage specimen, 22% of them will have pathogen detected by the multiplex panel, but not by sputum not by culture. And for sputum assessment, 27% will have that positive identification by the molecular technique rather than the traditional culture. So that's contributing to the low specificity of the BioFire test. Not because it's not a good test, it's because they detect more organisms compared to the standard of care or traditional method. Whether that's clinically relevant is another point of discussion, because culture detects live organisms, whereas molecular technique detects live and dead organisms, as long as they have DNA fragments. So that's something for clinicians to consider in the sense of not broadening too much, because not all pathogens detected by molecular technique will be the causative organism for the pneumonia. So we did, as part of the adoption translational research, we did a validation process at the lab at the Mater, and I have to acknowledge my colleagues, Dr. Fiona Parsonson and Sukhna for doing the work in terms of laboratory verification. So the plan is we had a 30 test provided by the company, and we used a commercial standardized, internationally recognized pneumonia verification panel, the natural, both the quantitative typical bacteria as well as the atypical bacteria and viruses as well. And those will be prepared into different pools, 30 pools of different combinations of viral and bacteria. And we have different concentrations being put into the pool, and we test the PCR technique. Because some of the test is semi-quantitative, so we want to really test the hypothesis that this test is valid in the lab. So we compare the performance of the test to what we know from the standard panel. An example of the pool that my colleagues put together is in pool 1, there's Acinetobacter, there's Enterobacter, there's E. coli, there's Klebsiella, with a couple of carbapenemase incorporated and ESBL genes in there, and Proteus and Serratia. And if I go to the next slide and just give you pool number 4, is a collection of viruses, including adenovirus, flu A, MERS1, paraflu, RSV, and 1 atypical bacteria, Legionella pneumophila. Just going back to the previous, we have bacteria in different concentrations. We're testing the semi-quantitative functions of PCR panel. Whereas here, there's all standard, pool 4 is all standard, because for viral detection as well as atypical pneumonia detection, the PCR multiplex technique does not give you a semi-quantitative result, just a qualitative yes or no in there. I'm going to show you what the result shows. The first is a pool 1 panel from our film array. It detected all the bacteria that we put in there, including higher level of Enterobacter and Klebsiella, which was what was designed, and Serratia as well, and lower level of Acinetobacter, E. coli, and Proteus. It picked up all the resistant genes, and it did not detect any typical bacteria or viruses because there were none. So that's an example of validations that we did. And the second panel this is the pool 4, to show about the viruses. All the viruses were detected, and Legionella was detected as well. So from a validation perspective, we did have one panel that did not correlate, and we repeated the test with additional pouch from film array. We found there was human error in the pool preparation rather than the film array. So it's 100% correlation in our lab validation, which validated the test for clinical implementation at the Mater campus. So what we are now doing, we got ethics approval. We are actively recruiting at the moment. We are looking at the feasibility and clinical utility in terms of guiding our pneumonia management. So we're aiming to recruit 60 patients over a 12-month period. So it started it's actually in April, and we are actively recruiting at the moment. And we're looking at 4 aspects of the trial. One is the timing of microbiological results. Second is the impact on clinical management in association with the ID or infectious diseases team. Third is the clinician perceptions and usefulness of the biofilm, film array. And the fourth one is the health economic analysis, which is a separate sub-study. to look at whether or not we could save money in terms of decreasing the use of antimicrobial and improving the outcomes and decreasing the length of stay of patients in intensive care unit. And the results will be presented at the 2024 Advanced Diagnostic and Physiological Monitoring in Critical Care Symposium. We've had 2021 and 2022, so the next one's coming in 2024, so you can check out the website. So I haven't got the results at the moment, but we're going to present the full results next year. Let's talk about the future. So I have seen and also collaborated with teams that use deep learning and AI in interpreting chest X-ray. We're also actively using point-of-care ultrasound to try to diagnose pneumonia, to improve precision and diagnosis of chest inflammations and infections in the chest. There is also studies ongoing about using molecular diagnostic techniques in bloodstream infection. That's a bit more complicated because it's much more genetic materials within the bloodstream. And there's this Edinburgh group that uses a robotic microendoscopy and fluorescein techniques to highlight white cells as well as pathogens in the lungs itself for a more precise diagnosis of pneumonia. In their case, it's actually for ventilator-associated pneumonia because you can pass a microendoscopy through the ventricular tube without having to give patients general anesthetics. And just quickly going through to a precision medicine, I think the future for pneumonia, to improve the outcomes of severe pneumonia, we have to really utilize the principle of precision medicine and personalized medicine. And one of the hallmarks of that, the foundations of that, is actually a fast multiplex real-time PCR, which I just spoke about in terms of the translational potential in clinical medicine. So in summary, pneumonia is a major global health issue and a leading cause of death. From my perspective, COVID-19 is an inflection point in telling us that molecular pathogen testing is feasible and is very useful in clinical practice. And we still have a lot of challenges in diagnosing and managing severe pneumonia. And I believe this multi-pathogen rapid testing panel basing on PCR is a very promising platform. And in my view, I think that's the core enabler of precision and personalized medicine. And that's the way we can focus on to try to improve outcomes in pneumonia overall. So I do thank you for that and welcome any questions.